comprehensive intervention consisting of exercise training and psychoeducational intervention. And we did test for physical capacity, quality of life, general health, and stuff like that.
Great. Actually, when you started this study, what was the rationale for you? Why did you think this is an important study to do so?
So in clinical practice, I saw these patients a lot, and I saw that some of them were managing life after an ICD very, very well and went back to live a normal life, feeling that they have a life-saving device, but others didn't cope so well with the device. And even though they felt that this was a life-saving device, potentially life-saving device, they still had some trouble adjusting to this. And we saw avoidance behavior where patients didn't dare to do certain things and didn't dare to live life with their full potential, maybe being afraid of physical activity or just not pushing themselves enough in life. So we really wanted to do something to support the patients to get most of life.
Okay, thank you. And the intervention that you developed for this study, can you elaborate a bit more on that? What were the active components of this intervention?
I guess in rehabilitation research until now, we often see that the exercise training component and the psychological or the psychoeducational component are developed in two different lines or really separately from each other. So what we wanted to do with this trial, we wanted to bring the different active components more together and make it a more complex intervention, both focusing on the physical exercise part of it, but also the psychoeducational part of it that is really a very central part of nursing. So we wanted to join in on this, and we know that we do complex intervention. It's really hard to know to figure out what should be the primary endpoint of this and what is really the most active ingredients in this, what is working, what is not working. But still, we wanted to test this comprehensive intervention because we felt that patients really both needed support in getting their body to work again and getting, making the full potential of the physical gains that they had by having the ICD, but still also making the head follow. And some patients say that, well, it's still anxiety is the worst thing. I don't dare to do things in life. So we wanted the intervention to be consisting of two parts. So the exercise training was a very traditional exercise program for cardiac rehabilitation. It was at that point, it was 2 times a week. Nowadays I would recommend more, maybe 3 or 4 times a week, but at this time we made the decision of 2 times a week. Both resistance training and aerobic training. And they could choose to come to the hospital to train here, or patients living far away or who were used to go to some kind of sports place to do it, they could choose to continue their own activities. So they could choose for themselves what kind of setting. We wanted all patients to come to the hospital for the first time to get instructions. They got a pulse watch to see if they were getting anywhere near the activation threshold of the ICD, and they were instructed how to use the pulse watch. We also wanted to use the pulse watch as like an reassurance that they were actually doing the exercise. So we also monitored the sessions to look for compliance. And the psychoeducational part of the program was rather comprehensive, and it was 9 consultations with the nurse within the first year. And that's a lot. And I thought long and hard about how much I should put into this, because there was also a financial thought that you have to give to this. But I really I wanted this to work, and I also wanted us to capture if anyone were getting an ICD shock and what would happen after that. So I didn't want to put, a too tight timeline for this. So we went on with this rather comprehensive program. So the patient and the nurse met face-to-face or by phone 9 times for the first year. In the beginning, it was 1 time a month, and then after 6 months, it became one time every 2nd month. And they discussed different issues and problems that we know are regular to these patients. So it was formed like an inspiration guide. So it was really patient needs that were controlling the conversation and what the nurse and the patient talked about, but still that there was some recommendation, and they had to talk about driving or sex or restrictions or physical activity and stuff. But the order of it was up to the patient's readiness and what else was going on with that specific patient. So we tried to make it very individualized, but still in a systematic way, so that we knew that there were certain elements to the intervention that we knew that the patients got.
Mm-hmm. Okay. Yeah, thank you for that. That's very enlightening to hear this. Mm-hmm. There are some questions coming in, but before we go on to the questions, so you explained the intervention. Can you also give a bit more information about the research methods that you have used? The design is a randomized controlled trial, but can you give some more information about methods?
Well, yeah, it is a randomized controlled trial. We wanted to make the most optimal design for this study, this trial. So, and it was a randomized controlled trial. We did make a sample size calculation prior to the trial. We did also publish a design paper where we explained the rationale and design of the paper. So we had 2 groups. They were randomized to intervention or control group. We included 196 patients, half in each group, 1-to-1. We were block randomizing these patients to make sure that we got an equal amount of patients in each group all the time, so it wouldn't be too influenceable by changes in clinical practice or new changes in treatment and stuff. And then we measured the outcomes after we did a baseline, and then after 1, 3, and 6 and 12 months, I believe it was, both questionnaires. We had a large pocket of questionnaires, and then we did also have the physical exercise test, the bicycle exercise test, and the 6-minute walk test. So and then we did blinded statistical outcome analysis, and revealed the results at a meeting with all the researchers being there. So that was
talking about the blinded endpoint analysis, this is one question, a question from Tini Jaarsma from Linköping, Sweden. Her question is, how did you do this blinded endpoint analysis, and why did you do so?
Okay. Yeah, well, the purpose of blinding is to reduce the risk of bias, of course, and when looking at the recommendation for blinding, you should blind both participants and clinicians and the data collector and the data analysts. And you know, I looked into it, and trials really show that non-blinded trials report larger effect sizes of I'm sorry, I'll try again. So non-blinded trials tend to have better outcome results than blinded. I'm not making sense here, am I? Okay, so if you're blind, it's harder for you to get a good result. So you should incorporate blinding into every step of the trial that is applicable to that design that you have. And then in rehabilitation research, it's really hard to blind the patients because they know if they get the intervention or not. It's also really difficult to blind the clinical staff. They know if they are giving the intervention or not. So what you can do is you could blind the data collector, and you can also blind the data analyst. And you do that because maybe the data analyst subconsciously would try and move on with some analysis, maybe not pre-planned analysis, to try to get the right results or the result that the researchers want for this trial. So to eliminate the risk of this kind of bias, we used the blinded outcome analysis, and we did it like this. We handed over the data to the analysis in a blinded manner. So the control group and the intervention group were labeled with colors like blue and red. And then the data analysis did the analysis and returned to the table with the researchers, and we had a session, and we asked him that he, when finishing the analysis, he should relabel the two groups so that no one in the room knew which group was which color. And then he should put in an envelope a paper saying which group he relabeled with what color. So we did the outcome evaluation, we looked at the results, and we interpreted the results not knowing which group was which group. So we made a conclusion saying if the red group is the intervention group, then the conclusion is like that, and we actually did write the conclusion. And the opposite, if the white group is the intervention group, then the conclusion will be like this. And then after finishing these two conclusions, we revealed which one was which one by opening this envelope. So this was really a very exciting way of doing it, and really a very good way of doing it, because we have so many things that we can't blind, so we can do it this way to make it a stronger design.
Yeah, that's indeed great. Another question that was posted also has to do with your research method, but in the meantime, I would like to invite the participants